Hello everyone. Today we are going to discuss about CNS infection as because this is the very important topic or for NEET examination and also in day-to-day practice also. As we know, CNS is made of brain, that means brain parenchyma, and the brain parenchyma is covered by a layer which is called meninges. This meningeal layer, which is contain three layers. One is arachnoid matter, one is pia matter, one is dura matter, and in between this brain parenchyma there is presence of ventricle. So any infection in this area is called CNS infection. That means infection in the brain or brain parenchyma or infection in the ventricles or in the meningeal layers causing CNS infection. So come to the definition of CNS, different CNS infection. One is meningitis. What do you mean by meningitis? Infection of the meningeal layer. That means this is the meningeal layer. This infection in this meningeal layer is called meningitis. Second is encephalitis. What do you mean by encephalitis? That means infection of the brain parenchyma. So any infection in the brain parenchyma cause encephalitis. What do you mean by meningoencephalitis? Meningoencephalitis means there is a diffuse infection of both this meningeal layer and also the brain parenchyma. This is mainly done by the viruses. So mainly the viruses causing meningoencephalitis. And if there is a focal infection in the brain parenchyma, that means if there is a diffuse infection in the brain parenchyma, that is called encephalitis. If there is a focal infection in the brain parenchyma, that is called brain abscess. Now come to the etiology of this meningitis. But before this, we have to know the CNS circulation. Say we have to know the CSF circulation and where from the infection come into the body. So first, the CSF is produced by the choroid plexus of the brain parenchyma. There is a choroid plexus present near the lateral ventricles. So the CSF is mainly produced by the choroid plexus present in the lateral ventricle and also in the fourth ventricle. So this is the blood vessels which produce the blood-brain barrier, and from this there is a, by the diffusion method, the from the blood the fluid comes out and produces the CSF. This CSF is mainly circulated in the lateral ventricle, and from the aqueduct of Sylvius comes to the fourth ventricle, and from the fourth ventricle is enter into the subarachnoid space. So the fluid is mainly present in the subarachnoid space, and the fluid is then absorbed by the arachnoid villi present in the subarachnoid space. And this arachnoid villi, by from the arachnoid villi, by the diffusion method, it enter into the sinus present in the subdural space. So by this, the CSF is get absorbed. So any infection enters from the choroid plexus is first enter into the ventricles of the and CSF. After that, this CSF, the infection is circulated. The bacteria or virus are proliferate in this CSF and they circulate throughout the meningeal layer from the brain. This causing there is a infection in the meninges, but there is also presence of the blood vessels in the brain parenchyma also. So if any infection enters from this blood vessels and enter into the brain parenchyma, this causes encephalitis, and this virus may again enters into the meningeal layer from the brain parenchyma, which causes meningoencephalitis. So by this way, the infections get attacked the brain parenchyma and also the meningeal layers. Now comes to the etiology of meningitis. So the most common cause of meningitis is the viral cause. That is means virus is the most common cause of meningitis. Among the viruses, most common virus which causing meningitis is enterovirus. There are different types of enterovirus, but the enterovirus itself is the most common cause of meningitis. In this lecture, I only discuss the meningitis which is more in the after the neonatal period. So in the neonatal period, the meningitis is caused by some other organism, which I will discuss in my next class. In this class, I am discussing the meningitis in the above after the neonatal period. So the most common cause of meningitis is viral, and after that, among the virus, most common virus is enterovirus. There are different types of virus can cause meningitis, just like enterovirus or Coxsackie virus, econovirus, arbovirus, or cytomegalovirus, and herpes simplex virus. Among the virus, herpes simplex virus can cause sporadic meningitis. This is an MCQ. And the herpes simplex virus 2 is causing meningoencephalitis as by the vertical transmission from mother to the child, because the mother's genitalia can infect by the herpes simplex virus type 2, and which causes meningitis to the child by the vertical transmission during the delivery. And this type of meningitis is very severe form, and this meningitis is mainly treated by giving acyclovir. So this is also an MCQ. Among the bacteria, the most common bacteria which causing meningitis is pneumococcus. In overall age group, the most common cause of meningitis among the virus is pneumococcus. Now come to some special cases. This all in MCQs. If the child is suffering from asplenia or sickle cell anemia, then the most common organism is pneumococcal. That means in asplenia or sickle cell anemia, the spleen is do not kill the virus or bacteria. The most common organism which is killed by the spleen is likely the encapsulated organism. So all the encapsulated organism mainly causing meningitis if the child is suffering from asplenia or sickle cell anemia, because in sickle cell anemia the spleen is having dysfunction. So the most common organism is pneumococcal virus bacteria. And after that, there is a Haemophilus influenza, and after that, there is a meningococcal. The meningococcal meningitis is the most severe form of meningitis. Is also an MCQ. If the child is suffering from T lymphocyte defect, that means the child is suffering from AIDS or SCID or CVID or Dyer syndrome, or the child taking chemotherapy or malignancy, the most common organism is Listeria. This is also an MCQ. And the most common drug and the drug of choice to kill the listeria is ampicillin. This is also MCQ. If the child is suffering from congenital or acquired CSF leak or CSF rhinorrhea, or there is a cribriform plate leakage and the CSF is come out from the cribriform plate, or the child having gone through cochlear implantation, then the most common organism is Streptococcus pneumoniae or pneumococcal meningitis. If the child having meningomyosip or lumbosacral dermal cyst, suffering from lumbosacral dermal sinuses, then the most common organism is Staphylococcus. If the child is suffering from CNS shunt infection, the shunt is mainly infected by Pseudomonas, and the most common cause of meningitis for this is Pseudomonas, and after that there is a Staphylococcus. If we found the temporal lobe or focal meningoencephalitis, then always think about HSV1, that means herpes simplex virus 1. And the drug of choice to kill the herpes simplex virus 1 is acyclovir. Now come to the clinical manifestation of meningitis. First, the meningitis patient having fever. This is the first and foremost sign. Any patient of having meningoencephalitis or encephalitis or brain abscess have to have the fever. So the fever may be having, child may having 1 day fever, 2 day fever, or suffering from some few days of fever also. After that, the child is suffering from headache and irritability. Why? Because after the meningitis, when the meningitis occurred in the child, when the virus bacteria enter into the CSF space, they proliferate in this area, and the neutrophil and lymphocytes which is present in this area are wants to kill the bacteria, and they try to engulf the bacteria, and they causing some inflammatory reaction. After the inflammatory reaction, there is leak. So there is a presence of interleukin which causes brain edema, and which is causing irritability and also the headache. And this headache is also mainly due to the presence of increased CSF, because the vascular permeability of the product plexus is having some default, because there is a inflammation and produces of inflammatory products. This inflammatory products which is present after there is a neutrophil or lymphocyte phagocytosis, this causing there is a increased amount of inflammation, and this causing vascular permeability, and that's why there is a CSF is increases in amount, and there is a leakage of the fluid, and the fluid is mainly can enter from the CSF to the brain, and also there is increased amount of CSF in the ventricle, which causes headache and irritability. After that, there is a presence of neck rigidity. Why neck rigidity is present? Neck rigidity is present because this high amount of CSF then enter into the spinal cord, and the nerve roots which are present and comes from the uh, spinal cord are get irritable by this inflammatory CSF, and this causing neck rigidity. And there is the presence of Karnic sign and Brzezinski sign. What is Karnic sign? The Karnic sign means we have to take the one leg in 90 degree position, and after that, if we take the cup muscle in extended position, there is a presence of pain in the cup muscle, which is due to the irritability of the nerve endings, nerve roots, and there is a presence of Brzezinski sign. Brzezinski sign means there are two types of Brzezinski sign. One is Brzezinski neck sign, one is Brzezinski leg sign. A neck sign means if we try to flex the neck, then there is a involuntary flexion of the hip joints of bilateral legs. That is called Brzezinski neck sign. And what is Brzezinski leg sign? If we try to flex one leg, then the other leg is involuntary flex by the nerve irritability. And that is called Brzezinski leg sign. This Brzezinski leg sign, neck sign, and cardiac sign is present after 18 months of age. This is also MCQ. There may be a presence of photophobia. Why photophobia is there? Because the retinal nerve having is covered by the meningeal gland. So the inflamed CSF is also present in the just below the retinal nerve, which is compress the retinal nerve and are causing irritability. So that's why there is a photophobia. There is a bulging frontonally may be present because the CSF amount is high, as because there is a leakage of the fluid. There may be a presence of seizure. So seizure is also present, and seizure is maybe focal seizure or generalized seizure. Why seizure is there? Because seizure is because if the inflammatory cytokines is enter into the brain, and which causes there is a inflammation in the brain parenchyma. This brain parenchyma by the inflammation may causing neural sinus defect, and there is a maybe presence of seizures. Then seizure may be focal or the seizure may be diffuse. There may be a presence of stroke. Because why? Because when the CSF get inflamed, the CSF can causes the vasoconstriction of the small blood vessels present in the brain parenchyma. So this there may be a presence of stroke, the focal stroke or general stroke. Next, there is a presence of papilledema. The papilledema is always present in chronic intracranial hypertension. That means if there is intracranial hypertension is chronic, then we only get papilledema. In acute cases, we cannot get the papilledema. So this is also tricky MCQ. There may be a presence of altered sensorium. Why altered sensorium? If the cerebral cortex is get involved by the viruses or bacteria, or there is irritability in the cerebral cortex, then maybe there may be an altered sensorium. An altered sensorium mainly present in viral meningitis. And there may be a presence of cranial nerve palsy. The third nerve, the trochlear nerve and the abducens nerve are get into the eye from this route, and there is a presence of CSF around the nerve endings, and this CSF when the CSF get irritable, they also causes paralysis in the nerve endings. So this can cause serious neuropathy. or cleaning pulses. Now come to the diagnosis part. So diagnosis is mainly done by CSF study. So the first and foremost examination we have to do, that is the CSF study. In adult, we have to take the CSF from lumbar 3 and between the lumbar 3 and lumbar 4 spaces, vertebral spaces. But in case of neonates, we have to take the CSF from higher up, that is means lumbar 1 to lumbar 2 spaces. In between lumbar 1 and lumbar 2 vertebrae, we have to take the CSF. And after taking the CSF, we have to see the pressure and we have to see the color. And we send the CSF for protein, sugar, counts, culture, and gram staining. In case of meningitis, the protein is high. In case of bacterial and in viral, the protein may be high to some extent. But in tuberculosis, the protein is much more higher. So in tuberculosis, protein is much more higher. In viral, the protein may be normal or higher to some extent, but in bacteria the protein is also higher. Why there is an increased protein in CSF in case of meningitis? As because there is a leakage of the blood vessels, and due to the blood vessels leakage, albumin rich CSF fluid is enter leakage from the capillary and enter into the subdural space and subarachnoid space, which causing increased amount of protein. Why there is a decreased sugar, and what will happen in sugar? In meningitis the sugar is decreased. Why there is a hypoglycemia? Why hypoglycemia or decreased sugar in CSF study? In case of meningitis, in meningitis the sugar is decreased as because the glucose transporter are damaged by the inflammation. So there's a glucose transport receptor is damaged in meningitis. So there's a decreased sugar. In case of bacteria, the sugar is decreased. In case of viral, the sugar is decreased or normal in some patient. In tuberculosis, the CSF sugar is also decreased. Count, the CSF cell count is mainly higher in any patient having viral or bacterial or tubercular meningitis. In case of tubercular meningitis, there is a lymphocyte predominance. In case of viral meningitis, there is a presence of lymphocyte predominance. In case of bacterial meningitis, there is a neutrophil predominance. But in the first, when there is a presence of infection in the primary stage, if you do the CSF study, in case of bacteria, there may be presence of lymphocyte much more higher than the neutrophil, and in case of virus, the neutrophil count is much more higher than the lymphocyte in viral in the first 1 to 2 hours after the meningitis is occurred. So this transition from neutrophil to lymphocyte in virus and a transition of lymphocyte to neutrophil in bacteria is occurred after 8 to 12 hours from the meningitis start. So this is also tricky. So if a patient comes to your emergency with 1 day fever with convulsion and you think about the child suffering from meningoencephalitis, if you do the CSF study, you will found the patient may having some increased amount of neutrophil count, but the culture shows no growth of bacteria. So this may be a child suffering from viral pneumonia. In case of viral pneumonia, the neutrophil count may be higher in the first primary 8 hours. So we have to keep in mind this tricky portion. After the CSF culture, we have to see the which virus or bacteria is cause the meningitis, and after that we treat by the culture sensitive antibiotic. Some more interesting part is in many patients we have found that the child already taking antibiotic for fever. So if any patient comes to you after taking antibiotic, so with the patient is suffering from meningitis, then in case then the child there may be no viral or bacterial culture is positive because the antibiotic may kill the bacteria. And there is a sterile CSF we can found. But then how do you diagnose the child may suffering from meningitis? In case of if the child taking antibiotic previously for oral antibiotic or IV antibiotic for 2 to 3 days, then we diagnose meningitis by seeing the protein, sugar, and the count. Because if the child is taking antibiotic, the culture, the virus bacteria may get killed, but the protein, which is much more in case of bacteria, is continually persistent for next 4 to 5 days, and the sugar is also decreased, and the counts, mainly the neutrophil count, in we will found in bacterial meningitis. So this is one tricky point. That means, so if a patient having treated partially by taking antibiotic, that means partially treated meningitis, then we always see the CSF protein, sugar, and counts. If the CSF protein is high, that and sugar is low, and the counts is mainly neutrophil, the child is suffering from meningitis, irrespective of the culture is present or not, or gram staining present or not. If we do traumatic CSF study, then there may be a presence of high amount of CSF protein. This will misguide our diagnosis. That means we will think the child is suffering from meningitis. But in case of traumatic TAF, their cell count is also maybe also high, or there is a presence of high amount of CSF protein. But in traumatic TAF, we have to be careful to diagnose the child is suffering from meningitis. So, in case of traumatic TAP, the CSF sugar will not hampered by the traumatic TAP. So, the CSF sugar will always decrease if the child is suffering from meningitis. If the child is not suffering from meningitis after traumatic TAP, if the protein is high, but the CSF sugar is not that much of low, that means the child is not suffering from meningitis. And also the culture have to be present in case of traumatic TAP. So in traumatic TAP, the culture have to be present, have to be positive. So that's why we gram staining also positive. That's why that's how we diagnose if the child is having traumatic TAP, traumatic CSF TAP. So these all are the tricky questions asked in all India MCQs, and also we are seen in day-to-day practice. So if there is a partially treated meningitis, we always see the protein, sugar, and counts. If the protein, sugar counts is positive, then we think about, and the culture is negative, we also think about the child is suffering from meningitis. If there is a traumatic type is present, then we also think about, if the sugar is low, then we think about the child is suffering from meningitis. Now, how much the sugar would be low? The sugar is low, less than 60% from the blood sugar. So when we do the CSF study, in when we do the CSF study, in that moment we take the blood sugar also. If the blood sugar is much more than the CSF sugar, 60% much more than the CSF sugar, then we always think about the child is suffering from meningitis. Now come to the contraindication of CSF study. When we do not do the CSF study, so before we do the CSF study, we have to keep in mind that the child may suffering from intracranial hypertension. So if there is a presence of signs of raised intracranial hypertension, the signs are raised intracranial hypertension are, one is bradycardia. So one is bradycardia. Second is irregular respiratory pattern, and third is hypotension. So this is the Cushing triad. So if the Cushing triad is present, then we always think about the child is suffering from raised intracranial pressure. So we do not do the CSF study. Why? Because if we do CSF study, then there may be a chance of brain herniation. That's why this is the contraindication of CSF study. Second is the child is suffering from severe cardiopulmonary compromise. So if the child is having severe cardiopulmonary compromise, then we do not do CSF study. And there is a local infection on the lumbar region. So where we have to do the CSF study, if there is a local infection is present, then we cannot do the CSF study. So that's why this is the three only contraindication of CSF study. Now, thrombocytopenia is a relative contraindication. That means the thrombocytopenia, if the platelet count is less than 20,000, we do not do the CSF study. That means it is a relative contraindication of doing CSF study. Now, come some tricky question. When do we repeat the CSF study? There is only two indication of doing the repeat CSF study. That is, if the child is suffering from gram-negative meningitis after treatment, we have to do a repeat CSF study. As because after treating by the antibiotic, the gram-negative organism in the CSF have to kill, and after 2 to 3 days, there is a sterile CSF may be present. If so, we have to do a repeat CSF study after 2 to 3 days to see there is a sterile CSF present or not. If the CSF is not sterile, that means the antibiotic is not working. And the second option is if the child is suffering from beta resistant streptococcus pneumoniae. If the child is suffering from beta resistant streptococcus pneumoniae, we have to do a repeat CSF study. Now come to the treatment part. It is much more important because the duration of treatment is much more important. In case of neonates, we have to give treatment for 21 days. This is very clear. In case of neonates, we have to give treatment for 21 days of antibiotic. Now come to the empirical treatment drug of choice for the treatment of meningitis. If the child is suffering from meningitis, we have to give empirical drug antibiotic for this patient before we found the culture report. So before the culture report come, we have to give treatment antibiotic as early as possible. So if you suspect a patient having meningitis, then you have to start antibiotic as early as possible. Even you start antibiotic before doing the CSF. Before giving antibiotic, you have to give a dexamethasone injection 2 hours before the antibiotic, 1 to 2 hours before giving the antibiotic. So 1 to 2 hours before giving antibiotic, you have to give dexamethasone injection at a dose of 0.15 mg per kg per dose in for 2 consecutive days. Why we have to give dexamethasone injection before the antibiotic? Because after giving antibiotic, there is increased inflammation because the bacteria is mainly killed by the antibiotics, and there is a profuse inflammatory strong in this CSF, and this may causing seizure, convulsion, and this inflammatory product may also hamper causing hearing problem of the child is mainly occurred in Haemophilus influenza infection. So to treat this complication, we have to give dexamethasone injection before giving the antibiotic. So what is the empirical drug of choice in case of meningitis? The empirical drug of choice is giving vancomycin and ceftriaxone. Why vancomycin and ceftriaxone is given? To kill the Streptococcus pneumoniae mainly, because Streptococcus pneumoniae is the most common organism which is causing meningitis, as I told before. So ceftriaxone is so Streptococcus pneumoniae is mainly sensitive to ceftriaxone, but if there is a beta lactamase is present, then vancomycin will work. So that's why we give vancomycin and ceftriaxone both in treating the meningitis. And what is the duration of treatment? The duration of treatment is 7 to 10 days. We have to give 7 to 10 days of ceftriaxone and vancomycin for the patient. And if the child is suffering from immunocompromised or gram-negative organism, then the empirical drug of choice before the culture report, we have to start antibiotic, that is meropenem, or we will give cefepime. So the drug of choice is giving meropenem or cefepime. Now, when the culture report come, we found that the child is suffering from streptococcus. So the most common drug of choice is most commonly used drug is ceftriaxone, and it is mostly sensitive, and the duration of treatment is 10 to 14 days. If the child is suffering from Haemophilus influenza, the ceftriaxone is the drug of choice, and the duration is 7 to 10 days. Neisseria meningitis is the most severe form of meningitis. Neisseria meningitis is causing most severe form of meningitis, and the treatment of the drug of choice is ceftriaxone, but the duration of treatment is less, that is 5 to 7 days. If the child is suffering from gram-negative organism, then we give ceftriaxone for 21 days. This is also an MCQ. If the child is suffering from listeria, then we drug of choice is ampicillin, and we give it for 10 days. So this is the drug of choice. Now come to the complications of meningitis. What happen if the child is suffering from meningitis? So if the complications of meningitis, the most common complication is deafness. That is sensor neural hearing loss is the most common complications of meningitis, and it is mainly occurred by Haemophilus influenza organism. So that's why we are giving vaccines against the Haemophilus influenza after 6 weeks. And the second complication is subdural effusion. Why subdural effusion? Because the leakage of the permeability, there is increased permeability of the blood vessels, and also there is a leakage of fluid from the vessels into the into the subdural space, and also there is a leakage of fluid from the subarachnoid space to subdural space, and it causing subdural effusion. And if the child having some symptoms of subdural effusion, then the treatment of choice is taking out the subdural effusion by by aspiration. And the third complication is the child may be suffering from CR. A child is suffering from viral meningitis, then always think about the child may be suffering from viral meningoencephalitis. So this is very important because virus when causing meningitis they mainly take causing diffuse infection into the viral into the brain parenchyma and also the meningeal layers, and that's why it is called viral meningoencephalitis. And the drug of choice and the most commonly used drug for to kill the viral meningoencephalitis is acyclovir. Now come to a tricky point. As I said, in viral meningitis, the CSF sugar glucose or sugar is normal or low to some extent, but in not like the bacterial meningitis. But in case of mumps, the sugar is much more decreased, just like bacterial meningitis. If the child is suffering from ecovirus, that means econovirus, then the protein is much more higher, just like viral meningitis. In case of polio, the child is suffering from much more higher protein, just like bacterial meningitis. So if we found the protein is much more higher but the glucose is normal and the CSF counts, there is a lymphocyte predominance, we think about polio. If the child is suffering from decreased sugar, just like bacterial pneumonia, but the protein is normal and the child having lymphocyte predominance, then we think about the child is suffering from mumps meningitis. Now, MCQ is the most common cause of aseptic meningitis. What is the most common cause of aseptic meningitis? What do you mean by aseptic meningitis? That means when you do the CSF culture is there is no growth in the CSF. That means aseptic meningitis. The most common cause of aseptic meningitis is partially treated meningitis. Partially treated meningitis is the most common cause of aseptic meningitis. After that, the most common cause of aseptic meningitis is mumps meningitis. So, mumps meningitis is the second most common cause of aseptic meningitis. So, this is all for the meningitis part. In next episode, we are discussing about brain abscess. Thank you.